So he's got the ACPO custody portfolio, and he's working very closely with Offender Health on the improving health and supporting justice. Andy, can I hand over to you?
An individual that's 3 parts policeman now and 2 parts NHS employee, which means that in terms of my perspective about breaking down the barriers, I have probably quite an unusual and personal insight about how the police service works, how the NHS works, certainly at a national level, at any rate, and actually trying to pull that together. So I thought let's just open this up, and I will try and make this as neutral as I can. Bear in mind I'm 3 parts policeman and 2 parts NHS employee. But if I told you I've been a policeman for 23 years, that might give you a clue about which side of the fence I tend to. Police service, siloed command and control process, as opposed to what I see in the health service, which is a far more networked approach to the way that you do business. That decision is made by the police service. Well, that's it. Go ahead and do it. Great, crack on, do it very, very quickly. And that sometimes can also present problems and challenges. As opposed to my perception of the NHS, which is far more collaborative, far more networking, far more dialogue, far more discussion. It means that you actually probably get to a better thought out position than perhaps the police service would, but it might take you a little more time to arrive there. The C word. The police service don't necessarily understand what commissioning is and what commissioning is about. We don't do it. When you come to talk about world-class commissioning, as health professionals, can you treat us gently, please? Because we won't always get it. In fact, you might even want to start with, do you understand how the health service works? The police perspective on guidance then, by default, as far as I'm concerned, what that conversation leads me to believe is the police perception of guidance is subtly different to that of the National Health Service, in that we don't see it as optional. We see it almost as Neil Ducar this morning was talking about what happens when mistakes are made, and in a really positive way, he was referring to them as moments of learning for an organisation. The police service don't tend to adopt that approach in relation to when mistakes are made. For us, death is a big issue. For the health service, I would argue death eventually is an inevitability. And lastly, last piece of language, a lovely example I went to, I think it was an event chaired by Sainsbury's actually, where the health service talks about those who are accused of offending, or TAOO as I'm now referring to it as, because I couldn't get it on the slide. And the police service will refer to them as suspects. And you might say, well, actually, that's quite derogatory, and I could understand that point of view. I could understand why you might say that, because actually we are putting you under suspicion. But actually, in the legal world in which the police service work, as soon as you are declared a suspect, you have certain rights and certain protection that you wouldn't if you think about the cultural issues that we will bump into, and we will rub each other up the wrong way. And I feel certain I may have already rubbed a few people up the wrong way in here this afternoon. The most important thing is that in our own worlds, we are both trying to make the world a better place. The health service is trying to make people healthier, the police service is trying to make people safer. And actually, I wouldn't want to be healthy without being safe, and I wouldn't want to be safe without being healthy. Support the idea that we can have better support, better clinical excellence, better understanding by the police service of what it means to have mental ill health or a learning disability, and that we can actually put that care pathway approach in place to make it happen, to make their worlds a better place. National Police Improvement Guidance Training on Mental Ill Health and Learning Disabilities, which is Bradley compliant in its entirety. It talks about offenders, it talks about 136, it talks about care pathways, it talks about liaison and diversion. Granted that we still need some very robust models around liaison and diversion to make it work. But in principle, what this means, signed by ACPO, endorsed by the National Health Service, is that actually we are on board with you in relation to these conversations. Over the next 2 to 3 years, is an upskilling in the police response to mental ill health and learning disability, to consider offenders and suspects as vulnerable people. That actually is a bit of an anathema to some police officers. Police officers like locking people up. We have a value system that says there's the goodie, that's the victim, there's the baddie, that's the offender, and why should we like the offender? We don't have to like them, but we do have to acknowledge their vulnerability. We seek to achieve a reduction in crime. We seek to achieve a strategic shift in our relationship with the health service, which will eventually lead to improved public confidence. I will now